Hello, and welcome to today's COVID-19 presentation on structuring isolation and quarantine sites for people experiencing homelessness with examples and guidance from Alameda County's Project Roomkey. I'm Caroline Gumpenberger, Director of Education with the National Health Care for the Homeless Council, and I am the moderator for this presentation. Our format for today's hour is a coffee chat. We call them coffee chats because they are informal conversations. We invite you to get a cup of coffee or your lunch and listen and discuss. This is an opportunity for us all to share ideas, challenges, and support for one another. We hope that you'll engage throughout the session. One of the best parts of a coffee chat is getting to hear from people doing similar work all over the country. So some instructions about how you can engage during the chat today. We want to hear from you, and we welcome your questions and stories throughout the presentation. The more you all engage, the better this chat will be. You can type directly into the attendee chat pod to the right of the slides. Your comments will show up to all participants, and I will refer comments and questions to the panelists as they come in. Before I introduce today's panelists, I want to point out the COVID-19 resources link in the resources pod. You can click that link and find all kinds of COVID-19 guidance specific to homelessness created by the National Health Care for the Homeless Council and other partners. Also in the resources pod are links to Alameda County's Emergency Hotel Shelter Handbook, which we will be discussing today, and other coronavirus guidance from Alameda County. You'll also find a link to the registration page for our next coffee chat this Friday, which will be on telehealth. And now I'm very happy to introduce to you our panelists today. They are Lucy Kasdan from Alameda County Health Care for the Homeless, and Dr. Harrison Alter of the Andrew Levitt Center for Social Emergency Medicine and Highland Hospital, Alameda Health System, both in Oakland, California. Welcome. I'm going to invite each of you to tell us a little bit about yourselves now and give us an overview of Project Roomkey.
Thanks, Carolyn. This is Harrison. I think I'm going to be kind of a minor player since I think the operational aspects of Operation Roomkey or Project Roomkey are kind of the most prominent, but I will start by introducing myself. I'm an emergency physician with almost 30 years in the medical safety net, most of which is at Highland Hospital in Oakland, California. I came to the project through our nonprofit research and advocacy institute, the Andrew Levitt Center for Social Emergency Medicine, as a volunteer to help support the clinical activities associated with Project Roomkey. I've been with the project for 6 or 7 weeks now, and it's been a fascinating ride.
And hi, good afternoon, everybody. My name is Lucy Kasdan, and I'm a clinical social worker. I'm the director of Alameda County Health Care for the Homeless, and I have been working in homeless services here in Alameda County for about 15 years. As Dr. Alter, the past 2 months have been really knee-deep in standing up Project Roomkey in our county, so excited to share with all of you.
Great. Thank you so much, Lucy and Harrison. If you could give us an overview now of Project Roomkey, that would be great.
Yeah, absolutely. So Project Roomkey is something that was designed by the governor of California, Governor Newsom, and California actually became the first state in the nation to secure FEMA funding to provide safe isolation capacity for people experiencing homelessness in California. In order to really protect them and, of course, the broader community. State and local governments, through this, are able to receive 75% share of costs through reimbursement from FEMA, and the reimbursement covers the hotel room as well as kind of the wraparound services, which include meals, security, and the custodial services associated with running the hotels, with the county then really stepping in to cover behavioral and physical health services and then working that through our community partners. This really started in Alameda County through 2 hotels that the state actually leased, the first 2 hotels that we used to stand up Project Roomkey, and in Alameda County, and if you have an opportunity to look at the policies and procedures that is included in this presentation. Here we've kind of taken Project Roomkey and divided it into two pieces, Operation Comfort, and that is specifically isolation quarantine housing for individuals who are COVID positive, have a pending test result, have confirmed contact with an individual with a confirmed index case, or have symptoms consistent with COVID. And so that is our Operation Comfort. And the second is our Operation Safer Ground, which is really housing for homeless individuals, really in the essence of a shelter in place. So identifying our most vulnerable based on the criteria that was established by FEMA, the most vulnerable, the homeless individuals who are most vulnerable to poor outcomes associated with comfort, and bringing them in. And so the first two hotels under Project Roomkey, that we stood up were leased by the state to Alameda County. And in fact, the service provider of those two, the community-based organization that's operating those two hotels, their contract is in fact with the state as well. And so those we stood up in early March, and those were, again, one is Operation Comfort, the isolation hotel, and one is Operation Safer Ground. And in total, those two hotels get us about 400 rooms. That has been the starting point for this. I can't emphasize enough how much standing up these hotels and ongoing, how much it really was a partnership across county departments. So I work within our county's healthcare services agency, but this was really a partnership between the county general services agency, social services administration, behavioral health care, public health department, kind of all these key county departments really coming together, our sheriff's department as well, really coming together to coordinate, and very distinct roles that each are holding in terms of being able to roll out and then support this ongoing. And so these really started with some pretty intensive planning meetings across departments, and then understanding kind of who holds what. So for example, and we will get into kind of some of the weeds a little bit more, but there are a lot of logistical considerations, things from PPE to how do you transport people, and so really how many security guards, what does that look like? How are we connecting people who are in isolation to services, so that there's continuity with pharmacy, all of those. It really started with bringing together all the key partners and spending some pretty intensive time together, kind of banging out the roadmap, which I think is really reflected in our policy and procedure manual. And through this, I will say that we've been able to, I think, really forge and strengthen partnerships kind of across county departments coming together for this. This also included, so again, not just with our county departments, but also really included working with our local hospital, which, as Dr. Alter mentioned, he is a physician on staff. Pharmacy, with pharmacies to really make sure that we are able to work out so that we were able to work with pharmacies to allow them to deliver medications, transferring people's pharmacies to allow people to deliver medication. As you can imagine, we have a lot of individuals here with really complex physical health needs, as well as substance use. And so that's included both, also working with kind of our methadone clinics, and then also being able to link people quickly to medication-assisted treatment services, and be able to bring behavioral health care services really on site to safer ground. And then the work that we're able to do with people in isolation, really relying heavily on the telemedicine component. So that's kind of an overview of kind of how this program, how Project Roomkey came to be and kind of the partnerships that came together for us to be able to roll these out. The last thing I'll say is, as I said, the 2 first hotels were leased by the state. What we have done in terms of being able to ramp up the programs are the county put out a request for proposals to hotels, which I know many other communities are doing as well. So put out a request for proposal to hotels looking to identify hotels that are willing to work with us, and I think really importantly, making sure that hotels understood and were agreeing to work with this population. I think that we've seen and heard from other places a lot of stigma and concern around hotels working with this population. Where's the hotel? And there's a little ruckus in the background. And so we are continuing to engage with, so while the state, they initiated the first 2 hotels, we are opening, and in fact opening our 3rd hotel tomorrow. And those are negotiated between hotels that have stepped forward and said, yes, we want to work with you. So those procurement processes have been negotiated at the county level. And so this week we are actually opening a 2nd Safer Ground, which again is for highly vulnerable folks. And the next Monday we're opening our 2nd Isolation and Quarantine Hotel.
That's great. Thank you so much for sharing that information. And now we'll move on to some questions for the panelists. As I said before, please feel free to enter any of your questions and comments into the chat pod, and we'll get to those as we can too. So I wanted to start with the guest agreement. The hotel handbook mentions that guests sign an agreement when they come and stay at your facilities. Can you give us an overview of what the guest agreement looks like and whether guests stay free of charge?
Yes. So guests stay free of charge. So there's no kind of payment associated with guests being here. There was a lot of discussion around the program agreement, and we know that different places have set this up differently in terms of to what degree you are using enforcement associated with people who may not be kind of sheltering in place. And we really landed on, after, again, a lot of discussion, really landed on wanting to make sure that we were rolling out a program that was equitable, and so that we weren't saying that we were going to apply a level of enforcement to homeless individuals at these hotels, that you and I do not experience that level of enforcement, and in our homes and with our neighbors who we may see not following these. And so really what it is about is making sure that kind of first and foremost, and I think even the first slide with kind of the picture, really making sure that this is a welcoming environment, that when new households, I should mention that these are households, so our youngest to date is 2 months and our oldest is 87, and people are allowed to bring in, so they are allowed to bring in kind of identified household members as long as the primary individual meets criteria and their pets. So we really wanted to make sure that this was kind of a welcoming environment, and that we really framed it much more around kind of harm reduction and education. And so I think that you will see that reflected in the program agreement, where we really talk with them about our expectations for them sheltering in place, and really kind of the ongoing education and reminders that we need to give people to, socialize a little bit, but make sure you're 6 feet apart, have that mask on. And it does outline in the program agreement consequences for individuals that are leaving their room frequently, and then other sorts of things. People aren't allowed to have guests here, right? And so so there is an enforcement piece, and there have been very few out of the Safer Ground site, which has 289 rooms. There have been very few incidents in which somebody's kind of repeatedly bringing in guests, that type of thing, where they unfortunately have not been able to stay. But it's really framed around having wellness checks with people daily, monitoring them for symptoms, having those reminders and education with them. So that's really what you see reflected in the program agreement.
That's great. Thank you. And I think we're going to return to a few of those points that you just mentioned in that overview in a moment. But I do see this question here from Harper Sutherland. If you're opening another IQ hotel, does that mean you're seeing increasing rates and numbers and the need for that facility? And I also wanted to ask if vacancy is ever an issue at either facility.
So I can answer the vacancy, and then I'll give it to Harrison for the so in terms of vacancy, at Safer Ground, at the Safer Ground sites, you know, we have on any given night in Alameda County over 8,000 street homeless, of which several thousand we estimate meet the criteria. So vacancy is definitely not. I think in the beginning it was more about kind of a safe ramp-up phase, right? How many households can you safely bring in a day as you're building kind of the community around sheltering in place and all of the complex medical and all of that stuff. Now, with Comfort, the isolation hotel, the occupancy is based on kind of the demand for it on any given day, and it ranges. And I will turn it over to Harrison.
So for Operation Comfort, which is the isolation and quarantine model, you know, we initially devised it as a sort of a pressure valve for both hospitals and clinics that had patients who weren't sick enough for hospitalization maybe, but did need to be isolated or quarantined depending on their exposure. And that capacity needs to be defined by where we are on the curve locally. And we understand that it's a dynamic relationship because the better we're doing over here, the more contribution we're making to flattening the curve regarding spread. So, and then, you know, of course, that reduces our demand, and it's sort of a positive feedback loop. We do need more capacity. We did lengthen by 3 days the minimum stay to 10 days. It kind of always was 10 days because we promised our guests a 3-day grace period, sort of warning period from 7 days of no symptoms, if that was their indication for coming to stay with us. So now everybody stays at least 10 days. And but that capacity, it needs to stay really plastic, needs to stay very flexible, because we have to be ready for outbreaks. You know, when there's a positive, for example, in an encampment, we need to go in and do contact tracing, and we sometimes will identify 7, 10, 15 people who had direct close contact with the index case, and we need to be prepared to move them all in. So we do need plasticity in our capacity for the isolation and quarantine hotel.
Mm-hmm. And that really is, so there's kind of the steady stream that are coming from hospitals, from our county jail, like there's kind of a steady stream. And then these kind of flux, you know, that happen. And I think we really err on the side of being able to offer. And just a whole different coffee talk around what it looks like to do that work in unsheltered settings in particular, that we've really been rolling out protocols around. But being able to really err on the side of caution and offer comfort to, as Dr. Alter just said, 15 people in an encampment who had contact, you know, close contact with that person, being able to offer to immediately bring all those folks in. And so that's where the census kind of ebbs and flows. I did want to talk about, I see that Michael Durham asked a question about harm reduction, and I apologize I didn't go over this in our overview. So we really made a very conscious choice, and I will say that I'm extremely proud of our county, and I'm proud of our partners in social services and our partners in our sheriff's department that really quickly got on board in understanding that, in particular in the isolation hotel, that in order for us to keep folks, right, in order for us to have folks accept coming into quarantine and be able to hold them there for that duration, that average length of stay of about 10 days, that it really was going to require us to really look at how we were going to be able to address things such as folks who are alcohol dependent. And so we, led by our pharmacist, Seth Gomez, the senior pharmacist with Healthcare for the Homeless, he developed, which are in there, kind of the dosing protocols around that. And so what that, do you want to describe it?
Yeah, I mean, it's a flexible model. We operate this at Operation Comfort only. We don't do it at Safer Ground, where people have access to alcohol more freely. But given that folks at Comfort are essentially in their rooms with scheduled chaperone breaks, and so they aren't free to go and purchase alcohol, we provide alcohol with meals in a staged manner according to their degree of dependence. It's titratable over time if we find that they're still exhibiting symptoms of withdrawal at, say, 2 drinks per meal, then we can, increase, or if guests are willing to, we can try to titrate down. And this is all managed through the nurses and self-report of alcohol withdrawal symptoms. There isn't formal monitoring of a CWA scale or anything like that. We do sort of shy away from the notion that we're a medical facility of any kind. So we thought that would sort of reinforce the idea that we are one. So it's symptom-driven, but sort of more informal than the typical symptom-driven protocol would be.
Mm-hmm. And it really goes along with being able to offer people nicotine patches, being able to offer people MAT, being able to offer people telepsychiatry. So all of those services kind of alongside being able to provide alcohol, as Dr. Alter outlined. I see there's a question about who the population is. So the populations for both are both sheltered and unsheltered. So there's not, it doesn't focus on unsheltered. I think that practically speaking, part of our initial wave in terms of filling safer, so for isolation, it's available to anybody who is homeless, and so it really ranges. For the safer ground housing, in the beginning, it was more weighted towards shelters because we started with decompressing our shelters to allow them to be able to do more social distancing. And so we first did work in our shelters to outreach and engage eligible individuals and bring them in to allow the shelters kind of more space. And then moved on to our unsheltered. And so it is a range and it is available to both. I think that more broadly speaking, what we have found is that in the safer ground piece, both, sometimes there are more logistical considerations in terms of people leaving belongings behind and kind of working through what that means in terms of people with large volumes of property or maybe who have structures at their encampments. And then with the isolation, I think what we have found is that it's more difficult for individuals coming in from an unsheltered environment, just the extreme of going into such a confined environment. And so that has led to us trying to figure out alternatives to really be able to support isolation and quarantine in encampment-based settings, while always, continuing to offer and encourage the isolation hotel.
Great, thank you. And I see we have a new question from Barbara DePietro here too. You mentioned using FEMA funds for the housing. Can you talk about the longer-term funding plan for the housing when those funds expire after the emergency?
Sure. So I will say at the outset that this is definitely lives in a separate department, so I'm not the expert on this. But the strategy that we have used, so for these hotels, we do have agreements through the end of June currently. While we have, and so a lot of what we have been doing is working to see what spaces might be available for us to kind of purchase and hold on to longer term. And so nothing to the scale of this this hotel here, but there are the strategy from the beginning has always been about kind of looking to identify sites that we might be able to kind of purchase and maintain long term to add to our PSH, permanent supportive housing, as well as our respite resources. And so knowing that kind of this finite period of time with FEMA, and again, we only have agreement, to my knowledge, through the end of June. And so I think that, Barbara, you're asking really good questions about, I think that, you know, what does it look like in terms of when these resources are no longer available, and what does that look like in terms of downsizing and exiting individuals? And I think that those are challenging questions that people are starting to have.
Great, thank you. And I do want to return to a question about discharge planning for guests a little bit later on, but first I was wondering if you all could give us kind of an overview of your staff structure and workflows at your sites.
Sure. So at Operation Comfort, the isolation hotel, there were 2 nurses, so 2 public health nurses from 8 a.m. to 8 p.m., 7 days a week. That site does intake 7 days a week, and we are now in discussions, in fact, of moving intakes to midnight, and so kind of seeing if that is needed to support primarily discharges from hospital later in the evening. And so during hours when there are intakes, there are 2 nurses on site, as well as our community-based organization that runs the site. They have 1 intake staff. They also have 2 site monitors that are on duty at all times that are checking in. As Dr. Alter was alluding to, there are scheduled breaks. Each resident gets 3 20-minute scheduled breaks a day, so they're facilitating those, checking in with individuals, helping with the daily wellness checks of people. And then there is 1 discharge planner there. So there's 1 staff that's specifically working to support folks in terms of their exit from, again, that very short average length of 10-day stay. And then there are 3 security guards on site at all times that kind of are in both stationary positions, and then 1 who roams. And then there is a program manager who kind of oversees, in fact, these 2 hotels are actually next to each other, and so who actually oversees both hotels. So 24 hours a day, there are 2 site monitors, and then during the day, there's the intake staff and the discharge planning staff.
There's also a clinician screener who is part of the intake process, who's available to the nurses and the outreach workers who have clinical questions. So the intake process, I don't know if
we didn't talk about that.
If we've covered that.
Yeah.
So there are, I think, about 130 community partners who are invited to refer guests to Operation Comfort. This includes shelters and street outreach programs and hospitals and clinics. If they identify somebody that they're working with who is homeless, and they're concerned that they are experiencing symptoms of COVID-19, or they know that they've been exposed directly to somebody who has coronavirus, then they will, they have a Google form that they get to initiate the intake process. That Google form then gets pushed to one of our volunteer MD screeners. We have about 20 volunteer clinicians, physicians, and advanced practice providers who then review the referral, which is very rudimentary when it starts, and they contact directly whoever is taking care of that person, whether it's a street outreach worker on a street corner with their phone on speaker so that they can talk directly to the potential guest, or if it's a hospital, speaking to the clinician who cared for the patient at the hospital or the clinic. And then the purpose of that step is sort of twofold. One, to assure that we're not getting people who are too sick for us to manage, that the hospitals are eager to disposition out of care. And on the other hand, somebody who just is very unlikely to have COVID-19, but is either nervous about whether, for example, a chronic cough represents a new illness. We're a little bit less aggressive about that side of things now that we understand the spectrum of disease to be much broader than we did at the beginning, but we still sometimes find people who probably don't need to come. So after that MD screening step is complete, then we push it back to the service provider, and they arrange for transport. You can see the photograph of the transport van. It's been given lots of different nicknames because of its appearance covered in plastic. The transport van is dispatched to wherever the incoming guest may be, whether it's a street corner. We try to be very specific about location when we're doing the screening, or to a hospital emergency department, and they'll transport maximum 2 people per run to keep them at greater than 6-foot distance within the van. And then they arrive at Operation Comfort, and they have another intake process, another step in the intake process, and that's going through with one of our public health nurses their medical history and their substance use history in particular. That gives us a chance to make direct referrals at the time of intake to behavioral health or to substance use disorder workers, whether they be through the California Bridge program or through the county substance use program, and also to, as Lucy alluded to transfer their prescriptions if they need to, if they come in with a less than 30-day supply, to one of our delivering pharmacy partners that was all arranged by our brilliant staff pharmacist, Seth Gomez. And there are a couple other steps in that process that, can necessitate a direct action. For example, we can arrange, this connects to the behavioral health issue, but if there's somebody that the intake staff perceives as being in crisis, we can arrange a telehealth visit when they get to their room, essentially, just to provide support and welcoming and to initiate contact with the telehealth provider. That happens, by the way, not through any fancy telehealth device that would need to be decontaminated after every visit, but rather through the hotel phone, which the guests have free access to during their stay.
And there are, so 2 psychiatrists and a psychiatric nurse practitioner who are also staff of healthcare for the homeless. They are the primary 2 staff who take those calls, and I see there's a question about this too. And as Harrison just said, it is purely done over the telephone for Operation Comfort, and both of those providers, and in fact we've been doing that more broadly with a lot of success, and so we have 2 clinicians who are very comfortable doing that, and we're able to also access kind of other collateral information to really help inform that and connect them to coordinate with also outside providers, if the psychiatrist, if they have one. So they are really the 2 that if somebody is flagged for that they're able to kind of step in and provide that service. Again, on the comfort side and the immediacy of understanding that that it is a situation for folks where we want to be able to step in quickly and provide all of those services to people. The staffing piece on the safer ground side looks different to some degree. So the ratio of kind of housing navigators who really work with folks on this, thinking about where they're going to go when they leave here and kind of coordinating all the care that Harrison was speaking about, the ratio is about 28-to-1 for those staff who, again, provide more kind of the case management services. So during the day, there are quite a few staff here. There are Monday through Friday or when intakes happen here. So there's nursing staff Monday through Friday to support intakes and support wellness checks. And then there are always two site monitors 24 hours a day, 3 security guards at all times. And then both sites have, as we talked about, the Dexter van, as we lovingly call it. But there's transportation on both sides as well. So that's really on the safer ground side. It's less, there's the ability, right, to provide in-person contact. And so but also telepsychiatry is also available on this side, but there also are behavioral health clinicians and SUD clinicians who are here to be able to outreach and engage with patients directly on site. So those are really staff from our partners in behavioral health care that come here to be able to provide that support, as opposed to kind of the staffing of the program itself with our CBO that really, again, includes a program manager, 2 site monitors at all times, 28-to-1 staffing ratio of those housing navigator positions. I see there was a question about, if somebody is strictly homeless, can isolate? That's a great question, and that comes up. Harris and I were actually talking about just before this call. That's complicated. The funding does define that people do need to be, meet technically the HUD definition of homelessness. It has been complicated because we have a number, right, we have people, we have seen a number of kind of outbreaks in unlicensed boarding care homes, various forms of kind of transitional housing programs, people who are doubled up. And so the new isolation hotel that's opening next week, that is going to have capacity to serve more broadly. And I think so some capacity to serve kind of a broader population, but to date it has been focused on individuals who meet the HUD homeless definition. And I should note that it is an individual, but like if it is the index case plus their partner that lived in their tent with them, they can both come and be in the isolation together.
Great, thank you so much. And I think that's a good segue to our next question, which is one of the pre-submitted questions. How do you ensure that staff, particularly at Operation Comfort, are staying in their respective rooms? And also, could you talk a little bit more about how the breaks are structured?
Sure. So it is tricky. So fundamentally, I will say, and this also goes to educating people before they come in, people do not have access to a room key, which fundamentally limits their ability to kind of come in and out of their room independently. Which, as an aside, there was some real emotional piece around that with some of the guests, and so part of the education that we're asking referring agencies to do is explain the rules, including letting them know that they don't have a key. But people do not have a key kind of fundamentally. They are, if they're seen kind of stepping out of their room, they're reminded that they need to step back in. They are allowed, and so staff come and actually escort them out for their 3 20-minute breaks a day. People are allowed to have pets, and so folks come out and walk their dog. There's a smoking area. And so people are, of course, at both sides are required to wear a mask at all times, maintain social distancing. And so, and then that escorted in and out of their room. In Comfort also, meals are delivered. Everything is delivered directly to individuals' rooms. And so all of those are kind of the structural pieces to really help them kind of making sure everything is brought to their room so there's no need for them to leave. And of course, it is challenging for people, and like everywhere, there have been people that have not been able to stay, not because they've been kicked out, asked to leave, but rather that that the environment is too kind of structured for them. It's too severe of an adjustment for people, and so they have decided to leave. But it's the constant reminders and education that the staff are doing and reinforcing, kind of, with people to really help them stay in their rooms.
So the closed door can be very triggering for people with a history of confinement or past trauma around confinement. And, we understand that it's an enormous step for people to accept. We do have, I wanted to say, a mobile medical van that comes to each hotel once a week. And they've been extremely helpful in kind of calming people's concerns about, their medical needs going unmet and whatever role that's playing in their difficulties in accommodating to the new environment. And I think that's true of actually a lot of our guests, that they just sort of wonder, what happens if I need a doctor? And so we've tried to make, I think, just people knowing it's there, not even necessarily making use of it, has been very soothing for many of our guests.
And I will just add on to that, and this kind of goes back to the question about the telehealth and any kind of lessons learned. I think that really how important it is, in an ideal world, which I think we've been very lucky here that we really have. So it's our Healthcare for the Homeless medical van. And the psychiatrists, right, are also Healthcare for the Homeless staff. So really having staff that have expertise in working with this population, I think, has really made a huge difference in terms of the interventions, in terms of the rapport building, the trust that they've been able to kind of create, and the willingness of the staff, of the providers to kind of step in and work in situations that some providers are not comfortable kind of working over the phone or kind of, in these spaces. And so I think that piece is really powerful, I think has been powerful, is having medical providers that have expertise in working with homeless folks who can really engage with them, I think has been really helped improve retention.
And we, when we ramped up admissions to Operation Safer Ground, we sort of decentralized the medical intake piece to the shelters. So we brought teams of volunteer clinicians to the 7 or 8 most condensed shelters in the Bay Area, in the East Bay, and did sort of massive screenings to transfer, 20 to 25 people at a time into safer ground from the shelters. These were teams of people who came from, our personal networks of contacts. So they were all people who were who understood the harm reduction principles that would be functioning on site and understood the specific needs of people who are shelter dwellers or people who are homeless. So we haven't really had to deal with another flavor of clinician who maybe don't view it as being quite the structural issue that it is, and maybe apply more personal accountability to it than is warranted. We do deal with those clinicians when we're taking referrals from hospitals, so we're reminded that it's out there. But within our little operation, we've been able to stay relatively apart from that kind of thing.
I see there's a question from Michael, and I love your questions. So in the intake that the guests do with the service provider. There is a grievance policy in the intake, so kind of the formal grievance policy for them. We also have here, which we haven't talked about yet, we have several peers who, in fact, as new guests come in, we try not to overwhelm them with too many things coming at them at once, but like within the first week of them coming in, have a peer call them and just check in with them. How is everything going? And so we've been able to get feedback from that. So again, the formal process as well as having peers reach out and check in, and then that has helped. And I think that you're asking about an example of that. An example of that has been a not fun example, or not that interesting, but I think one of the one that jumps to mind for me is around tracking and making sure, so at safer ground, people do come down and they line up with their masks on 6 feet apart to get their meals, that the barrier of that, that for some folks who it may be more, that may be because of physical health challenges, we need to deliver food to their room. So that was a bit of feedback from peers. The other bit of feedback from peers that we're looking to implement at the new hotel that's starting tomorrow is around some of the female guests feeling like, again, who have more histories of kind of trauma, feeling like they, that kind of being in a hotel room with men on both sides, kind of expressing some fear around that. And so thinking about how we bring people into new hotels so that we continue to kind of support having kind of a trauma-informed environment, and thinking about, does it make sense to kind of do some sorting and planning around that as we bring into rooms. So I think that those are really good pieces of feedback that we've been able to receive via the connection that people have with the peers.
Great, thank you. And I wanted to kind of expand on that a little bit and also touch on a point from the guidebook that says that guests can request or earn additional privileges. Can you talk a little bit about what that process looks like and what kind of privileges that includes?
Yes. Sorry, I'm laughing because that would look like, I mean, I think that the intention of that, and I will say I'm laughing slightly because, you know, I think as you all can imagine, and I'm sure as many of you have experienced, you kind of get a group of people together and you're working over a course of a couple weeks kind of putting together these guidebooks and kind of putting in these pieces. And I think that then there's kind of, when you roll it out practically, what makes sense. And so that is one that I am not aware to date that kind of has been implemented in terms of kind of adding additional privileges.
I mean, what it speaks to is that the service provider, and I can't say enough of that. Have you named them?
No.
Is it okay?
Yeah.
Yeah. So Abode Services, which is I think one of the largest homeless service providers in the Bay Area, has just been amazing to work with as a partner. And their staff really understand our guests. And so they are willing to work with them to find a situation that works both for the guests and works for the purposes of the isolation and quarantine. So they don't give a lot that is going to compromise the function or goal of the hotel in the first place, but they really do work creatively with guests to try to solve problems in a way that does serve both the purpose of isolation and quarantine and the ability of the guests to be successful here. So that's probably what they're referring to there. You know, if somebody's dog can't go for 4 hours between walks to pee outside, then they may allow that person to have 4 breaks if they have the staff for it, because the dog is going to pee in the room otherwise. So, you know, other people may complain, but they have a pretty good rationale for that person getting differential treatment. So I think that's probably the kind of thing that we were getting at there.
Mm-hmm.
Great.
I
Thank
see
you so
Megan
much.
asked, oh, sorry.
Go
Daily
ahead. I was
census,
going to ask the same question.
Oh. We can send that out. I mean, I think that it ranges, right? I mean, Operation Comfort has a capacity of just over 100, and the daily census ranges around 60-ish. Is that right?
For Comfort?
Yeah.
No, I think it's more than that.
Oh.
I mean, yeah, it's variable. It's variable because we do get big sort of we get big days. You know, for example, if we have an outbreak in an encampment, we'll get a big day. We'll get several people on one day, and most of those people, if they stay asymptomatic, they all get the same day assigned for checkout. So we may end up with 40 on a day, but usually I don't think we have quite that many.
Yeah. So it ranges, and the hotel is, you know, near enough at capacity all the time. Julie, I'm not quite sure what you're asking, so tell me if I'm answering your question right or not. Oh, okay. Caroline, do you want me to answer that, or do you want to?
Sure. No, go ahead.
Okay. With anybody that comes in that's receiving any sort of telehealth services while they're here, part of that would include us then making sure that we're connecting them with an ongoing care. So if they're seen by, say, a psychiatrist, part of that would then be making sure that we're connecting them to the appropriate level of behavioral health care services and a provider to continue their care. It could be that they stay with the provider because there are providers, so it could be that the person we have had that nice continuity of care. Otherwise, we are connecting them to other places.
Thank you, Lucy. And can we take that maybe one step further and maybe talk about how your housing and discharge plans are developed?
Sure. So I will say that with Comfort, with the isolation hotel, anybody that's coming in from a sheltered environment, so a recovery program, a shelter, et cetera, anybody that's coming in from a sheltered environment, the agreement is that they hold that space. And so those individuals come in for the period of time indicated and return back to their space. For other individuals, again, as most of you, we have, you know, a real scarcity of housing resources. And so, you know, a hotel room, or pardon me, you know, so shelter is offered to individuals. If there's capacity and they meet eligibility, they are offered safer ground. And so those, you know, so all kind of available resources are offered to people at the time they leave, again, based on what we can do in those 10 days. And it is very hard, I think, emotionally for staff to be able to bring in people who are at times quite sick and then not have very many places to offer them when they leave. With Safer Ground, it's really just getting off the ground. We are, part of the work was also overlapping this work with our coordinated entry system, so looking at our by name list or prioritization for individuals. So, and that was one slice of who was identified and brought into Safer Ground were people who are the highest people who met criteria who are on the permanent supportive housing target list. And so for that, you know, that segment of individuals, there are kind of ideally exit strategies. Some people came in already with vouchers and are just looking for housing, so there's kind of that range. And there are people coming in, we're really starting from ground zero. And so I think that some of that will depend on our ability to kind of expand and maintain capacity and continuing to do kind of all of the housing navigator work to support folks in identifying housing options and using housing flex funds and things to be able to support that.
Great, thank you. So we're coming up to the top of the hour. We have just a few minutes left, but without other questions in the chat, I wanted to ask about testing protocols. And I think, Dr. Alter, you had a little bit of information about this, maybe specifically for your guests at Operation Safer Ground.
I think protocol would be sort of a generous word for it. We have been able to test. We haven't formalized protocols yet. When we do the large volume intakes that are sort of decentralized to the shelters, we have been able to partner with community partners, particularly those through clinics funded by Healthcare for the Homeless, to do on-site testing with us while we're doing the intake for Safer Ground. So those people arrive at Safer Ground having been tested, not usually with the result. And then we have been trying to work with those partners also to come do some backlog testing here for people who arrive without a prior test. We are working on developing sort of a prevalence testing strategy that we hope to have up within the next week or two, where we will come to a Safer Ground hotel, whether we have more than one going at the time or not, and with some as yet undetermined periodicity, go and test everybody in the hotel. So, you know, rooms 100 through 300 on Tuesday, 300 through 600 on Wednesday, et cetera, and then come back 2 weeks later and do the same thing. And that's probably the way that we can assure that we're doing everything we can to keep virus out of this highly vulnerable environment. We don't have any protocols built around a negative test at either of the operations because of the unreliability of a negative test, but we do use positive tests to move people from Safer Ground to Operation Comfort. And we just, again, try to operate here at Safer Ground under the assumption that anybody might be a false negative asymptomatic carrier of coronavirus.
Great, thank you so much. Well, we're closing in on the top of the hour now, and without additional questions, I just wanted to take a moment to thank everybody for coming to today's coffee chat. Thank you, Lucy. Thank you, Dr. Alter, for this great presentation. This session is being recorded, so we will have the recording and the accompanying materials from the resources pod available on our website within about 3 business days. I also wanted to point out one more time our upcoming coffee chat on Friday using telehealth services for patient care. You can access the link there for registration if you're interested, or again, the link for registration is also in the resources pod. If you have any questions or would like additional information, please feel free to reach out to us at any time. We also have technical assistance available that can be requested through our website. And thank you all again for coming. We really appreciate you, and this webinar is now closed.